All right, if you're gearing up for your anesthesia finals, you've come to the right place. You absolutely need to know abdominal compartment syndrome inside and out. So, in this high-yield explainer, we're going to cover all the critical points you'll need, not just to pass your exam, but to manage some of the absolute sickest patients you'll ever encounter.
So here's our game plan for today. We're going to start by locking down the key definitions. Then we'll dive into the pretty devastating pathophysiology. From there, we'll cover how to diagnose and manage it, and we'll wrap up with the anesthetic considerations, which, let's be honest, is the part you really can't afford to get wrong in the OR.
Right, first things first. To really nail those exam questions, you've got to have these definitions down cold. Let's break down the crucial difference between intra-abdominal hypertension and full-blown abdominal compartment syndrome.
And let me tell you why this is so critical. Untreated abdominal compartment syndrome has a mortality rate that gets terrifyingly close to 100%. This is a diagnosis we just cannot afford to miss, period.
Okay, so the whole dangerous journey starts here, with intra-abdominal hypertension, or IAH. The magic number you need to remember for your exam is a sustained pressure greater than 12 millimeters of mercury. This is your first big red flag.
And from there, things can escalate to abdominal compartment syndrome, ACS, when two specific criteria are met. First, the pressure is now sustained above 20 millimeters of mercury, and second, and this is key, you start to see evidence of new organ dysfunction. So remember, it's the pressure plus the end organ damage that defines the syndrome.
And this table? This is a classic exam question. This grading system for IAH is a simple 1 to 4 scale, based purely on the pressure. You're definitely going to want to have these numbers committed to memory.
You know how we obsess over cerebral perfusion pressure and neuroanesthesia? Well, here, we need to be just as obsessed with abdominal perfusion pressure. The formula is super simple. It's just your mean arterial pressure minus that intra-abdominal pressure. And the target you're aiming for, the one that's been shown to improve outcomes, is an APP greater than 60.
All right, so now let's get into the why. Why is this so bad? Well, this buildup of pressure doesn't just stay put in the abdomen. It kicks off this devastating cascade of multi-organ failure.
And wow, this image really paints a picture, doesn't it? It shows just how global the impact is. We're talking everything from increased intracranial pressure to renal failure and gut ischemia. Literally no system is spared. It's a systemic disease that just happens to start in a single compartment.
The cardiovascular system gets hit with a nasty double whammy. The vena cava gets squashed, which absolutely tanks your preload. At the same time, all those abdominal vessels are compressed, which jacks up your afterload. The end result? A really dangerous drop in cardiac output.
And in the lungs, the physics are simple but brutal. The diaphragm gets shoved way up into the chest, splinting the lungs. This leads to atelectasis, a horrible VQ mismatch, and a vicious cycle of rising ventilator pressures, hypoxia, and hypercarbia.
The kidneys? Man, they are uniquely vulnerable here. They get hit from both directions. First, the arterial blood flow into them is reduced because of that low cardiac output. And second, they're being directly compressed, which obstructs both venous outflow and the drainage of urine.
And here's the really clever but devastating physiological point you need to grasp. The intra-abdominal pressure doesn't just attack the filtration gradient in one way, it attacks it in two. It reduces the incoming perfusion pressure, and it directly opposes filtration. It effectively crushes the kidney's ability to do its job.
Okay, so we know how devastating this is. The next logical question is, how do we actually find it? Well, the answer is all about having a high index of suspicion in the right patients and then getting an accurate, direct measurement.
So the World Society of the Abdominal Compartment Syndrome, or the WSCS, has given us some really clear guidelines. You should start monitoring any patient with 2 or more risk factors. And these risks fall pretty neatly into 4 categories: a tight abdominal wall, too much stuff inside the bowel, too much stuff outside the bowel, and massive fluid shifts from capillary leak.
So don't even think about just palpating the abdomen. Study after study shows that clinical examination is highly unreliable. You have to measure the pressure. And the gold standard indirect method, the one you absolutely need to know for your exam, is via an intravesical or Foley catheter.
For your practical exams or OSCEs, these 5 steps are pure gold. Listen up. 1. The patient has to be supine. 2. You zero the transducer at the iliac crest, right in the mid-axillary line. 3. You instill no more than 25 mL of saline into the bladder. 4. You wait 30 to 60 seconds to let that detrusor muscle relax. And 5. You take your reading at end expiration.
So you've got your measurement, you've diagnosed IAH, now what? Well, the good news is there's a very clear stepwise management algorithm that guides us through both the medical and surgical interventions. And this right here, this is your roadmap from the WSACS. Notice how it's not just about jumping to surgery. It starts with medical management for any IAP over 12. If that fails, or if the patient develops full-blown ACS with organ failure, then it guides you towards surgical decompression. The key is that constant reevaluation of the IAP, and maybe more importantly, the abdominal perfusion pressure.
Before we even think about calling the surgeons, we've got a whole toolbox of medical management options. These strategies all focus on 5 basic goals. Relax the abdominal wall with things like sedation or paralysis. Get stuff out of the gut with NG tubes or enemas. Drain any free fluid like ascites. Very carefully manage fluids to avoid making things worse, and, of course, critically support that organ perfusion.
Now we get to it. This is probably the most critical section for your exam, your role in the operating room during a decompressive laparotomy. You have to be prepared, because these are some of the sickest, most fragile patients you will ever manage.
You need to have 4 potential disasters on your radar. 4 things that can happen the second that surgeon's knife opens the fascia. You're going to see altered drug handling, a sudden change in respiratory mechanics, a massive drop in blood pressure, and a huge systemic inflammatory hit from reperfusion. I really want to hammer this point home. The instant that pressure is released, the systemic vascular resistance is going to absolutely plummet. This can cause profound, life-threatening hypotension and even cardiac arrest. You have to be one step ahead. Have your fluids wide open, have your vasopressors literally in your hand, and have all your resuscitation equipment ready to go. Be ready. All right, we have covered a ton of ground. Let's finish up by boiling all of this down to the absolute must-know takeaways for your exams and, more importantly, for your clinical practice. Okay, here are the 5 things to tattoo on your brain. 1. IAH is common in the ICU, and it's a killer. 2. It presents as a multi-organ failure. 3. You cannot trust your hands. You must measure the pressure. 4. Your main resuscitation target is an abdominal perfusion pressure over 60. And 5. Surgery is a powerful tool, but it's just one part of a much broader medical strategy.
So this gives you the framework, but we all know that safe practice means always thinking 2 steps ahead. So I'm going to leave you with this question to chew on. The abdomen is open, the blood pressure is stable, for now. What are you going to do right now with your ventilator settings to manage that suddenly compliant chest wall? And how are you going to tackle the inflammatory cascade, the reperfusion injury that's about to hit the circulation?
And just so you know, all the information in this review was adapted from this fantastic 2012 review article by Barry and Fletcher. Good luck with those finals. You got this.